Hi and welcome to another video. Today I'll go over hemochromatosis. Hemochromatosis is an autosomal recessive condition which results in too much iron to be absorbed, which over time may lead to organ damage. In terms of statistics, it is estimated that 1 in 10 of those with European descent carry a gene that may affect iron metabolism. The most common mutation within hemochromatosis is the HFE gene mutation. For some brief pathophysiology, there is a dysfunction of the HFE. This in of itself results in hepcidin hormone levels to lower, which itself causes macrophages to release iron from red cell phagocytosis, which occurs in an unregulated manner due to their reduction of hepcidin. This in turn results in iron accumulating in the organs, which over time results in organ damage such as liver cirrhosis, pancreatic dysfunction, and heart issues. For the clinical presentation, your early symptoms are arthralgia, chronic fatigue, and erectile dysfunction, which you can remember through the mnemonic ACE, whereas the typical exam triad includes bronze skin, diabetes, as well as abdominal pain and distension. Other features to be aware of includes cardiac failure, hypogonadotrophic hypogonadism, as well as liver cirrhosis, which I mentioned in pathophysiology. Different investigations may be undertaken. In terms of the iron profile, you would have a transferrin saturation of over 50%, and ferritin levels would also be raised. However, your total iron binding capacity would be low, as there is a dysfunction and the ability for the body to bind to the organ is decreased as a result of the mutation. In terms of your liver function tests, those may become deranged and your aminotransferase levels might be high if there has been extensive damage to the liver, but they may also return normal depending on the level of injury. Genetic testing may be performed to check for any family history, and HIV mutation analysis is key, particularly when looking at the C282Y and H63D polymorphisms. With regards to the blood sugar levels, they may be raised, but it depends on the stage at which the patient is diagnosed. Your testosterone, follicular stimulating hormone, and luteinizing hormones may be lower than normal in patients who also have hypogonadism. The management, first line, is venesection. It is done to keep the transferrin levels below 50 and it is quite effective. You may also perform an iron chelation therapy who may not be able to have phlebotomy, and that is due to things like anemia, heart disease, or access issues, or venous access issues. And therefore another option for those patients is desferoxamine, which is given parentally, or desferasirox, which is given orally. Lastly, but very importantly, you should have regular vaccinations or advise patients with hemochromatosis to receive regular vaccinations, especially for hepatitis A and B, as they are already at an increased risk of developing liver cirrhosis. That's all I have for you today. I hope you found this video useful. If you have any questions about hemochromatosis, feel free to leave them down in the comments. Other than that, thank you so much for watching. I hope you consider liking and subscribing for more videos like this.